Hey everyone, this is the Manips Sips podcast. We've got a special episode today as Brandon and I are here together. We'll talk more about that later, but we got a special guest today, Steve Kinney, if I'm saying that right. Did I get that right? Yes.
You got it correct.
Today we're going to be talking about why you shouldn't specialize or go into specialization, which is kind of interesting coming from three of us who are deep into specializations, as we would say. And then we'll kind of go into a couple other things, but yeah, how's it going, everyone?
Everything's going great, man. Steve, thank you for taking the time out of your busy life with work and family to do the show with us. I see he's repping his Regis University OMP t-shirt, so way to represent here. Jeremy and I got the green light to do some mentorship for Jeremy's program, so he's up in my office. That's why we're here together. Mm-hmm. He's home turf, so he has to drink some whiskey, so that's what he's drinking today.
Check out the glass in true Brandon fashion.
Vertebra. So
hold like this. You know, what kind of hold? Do I do a UPA on this?
Or do whatever your heart desires. Man. But I do, before we get into drinks, I want to introduce our awesome host here. I mean, I met Steve in our fellowship program. He's from Jersey, lives in Indiana now. Bright mind here, kind of has worked in a lot of unique settings, and I'll let him talk about that in a little bit. He's now in Indiana, also doing a lot on the advocacy side for the state and for the profession, which I think is awesome. I've had the pleasure to see Steve grow over the past couple years from when we first started Regis, and kind of how he's gotten more involved in things like that. So Steve, I'm going to pass it off to you. You know, give us a little background where you went to undergrad and PT school and kind of what's been your track. And then we'll do, I guess, a drink introduction, and then we'll get into the nitty gritty.
Thanks a lot, Brandon. It's been, obviously, as Brandon said, I've known him for a while through the fellowship program, and he's been a great person to work with through the fellowship program, and his clinical skills, awesome. And it's great to learn from you.
Thank you.
But what I would say is my career path has kind of been a little interesting. When I always knew I had an interest kind of in everything in PT, so there's not a lot of things that kind of like scared me too much, with maybe the one exception. I really don't want to do like internal pelvic floor stuff. But I would say beyond that, I started off working in a brain injury unit in New Jersey at JFK Johnson, which is it was a model program for TBI. So I had some really interesting experiences there to start my career, where we're working even with like patients with disorders of consciousness, and some pretty severe cases like that, multi-trauma. And I think that kind of built a base for me to kind of build off the rest of my career. I worked in acute care basically throughout the years, kind of more as like a part-time thing, generally speaking. I've worked in general inpatient rehab, and then also orthopedic physical therapy for probably much of the last like 6 or 7 years. And when I've been doing outpatient physical therapy, a lot of it's been in an orthopedic setting, obviously, but I've been fortunate to work with some pretty big hospital systems where I'm working also with neuro patients, vestibular patients. And then I've also had to do a lot of rural health, probably increasingly in the last 5 years as well, which with rural health, you kind of have to know a little bit of everything, because people has come through your door and they need a physical therapist, and there's not really many options to treat stuff except you there. So if you don't know it, you have to kind of figure it out, which I think is awesome. And I think now, knowing my kind of career path a little bit, I think being able to treat those types of populations where you have to know a little bit of everything is good. Or I really like those complicated patients who come through where it's like, well, they got like 4 different things involved. And I'm like, hey, you know what? Yeah, you got a vestibular issue. Yeah, you got a cardiac issue, and you have an orthopedic issue. I'm the person who can kind of tackle those different 3 things. And I like that challenge.
Yeah, that's awesome. And that's going to be the crux of our show. So before we get into the meat and potatoes, what are you drinking today? Let's do the drinking. A little hour today, but it's okay. It's all good.
Yeah.
I'm having a Madras, which is a orange, cranberry, and spice mead, which we were talking about before. Mead is like a halfway between a beer and and wine, I guess.
Okay. Awesome. So I didn't know what a mead was, and you explained it to me. What is it made with? Beer typically, and versus what a mead is, just so everyone gets a little background on that.
So I think beer is a little bit when you have like the yeast and the sugar, and there's, I guess, heating during that fermentation process, where mead is kind of made a little bit more like a wine, but it's instead of sugar being given to the yeast, I think it's honey. So I think honey is the characteristic of a mead.
Awesome.
Sometimes they're good, sometimes they're bad. This one is very good.
Very nice. And it seems you got a nice sized bottle there for today's episode. So it's going to be a good one. Jay, what you got? Oh, sorry.
For any of our listeners and those sort of things who are in New Jersey or close to it, Armageddon Brewery, I believe I forget what town is in, kind of by Flying Fish, which is Summerdale, I think, is just a mead brewery. So if you just want to test out meads, actually craft made, it's there for you. But one question before I get in my drink, Steve, was that JFK in New Brunswick?
That was no, it was before that became part of that hospital system. It was in Edison, actually.
Okay, yeah, I was born at that hospital, so.
Oh, really? Oh, awesome.
That came to mind. I was like, got talked about that, but I am drinking what my main man hooked me up with, which is what Noble Oak.
Noble Oak, yeah. So it was left in the cabinet in the office.
Delicious. I do like whiskey. I'm more Irish whiskey and bourbon is my go-to. I'm not as big into Scotch, but this was in Jeremy Boyd scale. Let me get a good sip. That's good. That's refreshing. Not too much bite, just right. I'm gonna give it 8 flat. 8 flat. That's smooth. I'm gonna be. I was like, oh man, I haven't just sipped on.
You know what? Today would have been a great day if I remember, if my brain was working, to bring in the Booker you got me, and we could have cracked that baby open.
Oh,
I messed up.
Yeah, we know this.
So sorry. All right, and I'm drinking the same thing, Noble Oak. We finished off the bottle here with the pours, so after this, that will be done. So I guess moving on, Steve, where'd you go to school? And then kind of what set you along those paths that you talked about kind of in the opening-ish of the show? And then, why did you end up, you've worked in all these different settings. What made you go through fellowship? And you did a residency, correct?
I did not do residency.
Oh, you did not? Okay, I'm sorry. Yeah, so if you could kind of, explain, I guess, from DPT school, where you went, and then how you went to each setting you did, and then how that's led you to now, because it's going to definitely lead to the topic of the conversation of why we shouldn't always specialize in PT.
Yeah, well, so actually I went to physical therapy school at Columbia University in New York. And one of the things they actually force you to do in your third year is they force you to take on a specialization track. And I kind of was deciding between ortho and neuro, and both of them seemed pretty interesting to me. And actually, weirdly enough, I actually took the neuro track at that point in time. And I think that was, I guess, helpful in toward me going into my first job where I worked predominantly in a neuro type setting. But then after that, as I got more into orthopedics, when I was initially exposed to physical therapy, before I even had gone to grad school when I was an undergrad and I was getting treated, I think one of my passions was it was cool to see how good physical therapists treated me and how there were some people who provided treatments who I would not like to replicate their care. So I think that also made orthopedic physical therapy an interest of mine, because sometimes it's, as a skilled clinicians can get immediate results and can do amazing things for their patients. So I think I always wanted to keep my hand in all of these different fields. And I think that's where during my career path, I kind of saw that. And as I did progressively more and more orthopedics, I saw a chance to develop more expertise and to grow professionally going through a fellowship program and I sat for the orthopedic certified specialist exam. So I didn't get residency, so I'm only half as cool as you two. And
I don't know about that, but yeah.
But I think one of the main reasons that realistically why I think a residency would have been a great experience for me, it just didn't happen because I just financially didn't think I could take on two of those types of investments. I can only really do one.
Well, if you did a residency, would that have faltered or limited the growth that you've been on in your career? Because if you would have specialized, would you then have dabbled in all the different things you did dabble in that has led you to this point? Kind of like that butterfly effect. So
yeah, and I think that also kind of played into it a little bit too, because I know I like moving around and doing all these different things. So it probably would have pigeonholed me, for lack of a better word. So I think that was part of the benefit too, because there's still things I do like learning about now. And I've had some recent exposure to stuff on wound care, and I am not a wound care therapist right now. I've changed like 2 wounds in my life, and I'm lucky at one of the locations I work at infrequently. Sometimes they're willing to actually show me how to do that. And then actually an area that I'm getting more into, and again, kind of limited, would be like kind of pelvic floor type physical therapy. I don't love doing it. I'm not going to do anything internal, but when you're in a rural setting and someone has incontinence and the next person's like 45 minutes away, you have to at least be able to do some basic or external stuff, because then the problem just doesn't get fixed. And I might not be the person to fully solve it, but I can get them on the right path, hopefully.
Yeah.
So what's the laws or the scope of practice in Indiana for a male PT to do that? Can you do it to another male, or no, you can't, and you're just working solely external, but maybe assessing the lumbar spine and maybe the pelvic and hip region?
I would say like you can access the pelvic floor muscles externally, and it's, if you think about it, like someone comes in with back pain, I might, let's say, have like for 20 tricks or something like that. For someone who comes in with pelvic floor issues, I maybe got like 4 or 5 tricks for that. So I can kind of externally access all the pelvic floor muscles. Sometimes I don't need to even do a targeted intervention to that area. A lot of times I have someone who has pelvic floor issues. I'm like, look, we're going to do a lot of what's commonly referred to as core stability training. I like kind of like motor control or neuromotor re-ed. And I will kind of work on kind of that stuff you would with a lot of our patients that you have with low back pain, and kind of start there. And if they need further stuff, I'll do the more targeted approach, or kind of refer them out to the appropriate specialist. And I realize that the referrals are going to have limited effect just because it's such a far drive for people who might not even have enough gas money to drive the 5 or 10 minutes to my clinic.
Yeah. Wow. How long have you been in this type of setting for? The current setting that you've been?
It's kind of off and on. Another thing that's kind of contributed to my weird career arc is I've been a float therapist for many years. So there's been, like, I'll cover at a clinic like for maternity leaves or for extended stays. Sometimes it's just vacations. Sometimes I'll just be like, it'll be a one and done type thing. But you see a lot of volume of patients, and you see a lot of the good and bad in physical therapy. And there's so many of my exercises I've poached from other people, which I think I'm very lucky to do. I'm like, oh man, that's a really cool exercise. And I might not like anything else that therapist does, but that there's could be like one exercise I steal from, or one technique that I steal from them. Yeah. And that means that probably goes for my coworkers too. I try to be very cognizant of trying not to blow up entire programs, but trying to like tweak things a little bit, and hopefully finding something where my coworkers could be like, oh, I like that one tweak you do, and this is something we could use effectively for this patient.
Yeah.
So we're gonna ask.
No, I think a good example of someone like you. I didn't watch the whole thing, but on Netflix there was this, right at the start of the pandemic, there's some sort of docuseries on like viruses and those sort of things, and they discussed like they followed this primary practitioner who has to legitimately, it's small rural town, I forget where it was, can't really remember much, but she has to treat everything from fractures, sprains, to neurological things, to delivering babies and those sort of things. So when I started hearing you talk about that, Steve, I thought that was you, and I think that's super cool. And I think you bring up a good point. You brought up the thing of expertise, and I think a lot of that's confused with as you become an expert, you become more specialized. And with what you're saying, you're becoming an expert and not, you're still being able to dabble into a lot of these things and still give effective care. So I think that's a really cool point to drive home to our audience and those sort of things. You don't have to go down one rabbit hole in order to become an expert. You can, be very good at a couple different realms there.
Yeah. So with that, kind of some follow-up questions for you and the audience, and in no particular order here, but you and I know this. We had this conversation, a great bunny trail in fellowship, where Cam and the mass knowledge he has and the wily veteran that he is, kind of talked about. I hope you were at this one because I know you missed one with because of a wedding.
Yes.
Shit, you might actually not even met this weekend, but we said, now that I think about it, we talked about how becoming an expert, we shouldn't specialize, and by specializing and limiting yourself, and we really mean specialization like one joint, right? Specializing in the shoulder or specializing in ACLs or treatment of the knee, you miss like the full picture, because the shoulder, is hinged off the T-spine, the C-spine, the shoulder girdle, all these muscles, even core or core control, rotational control, things like that. So if you're just a shoulder specialist, are you missing all these other things that are part of the bigger picture and therefore not as effective of a treating clinician now that you've done that? And then with your career arc, like you were saying, how do you think that's kind of really been to your advantage? And then another kind of follow-up question with that, you went through OCS and then into fellowship, and you're about to complete that. How has this unique specialty of fellowship training really helped you become more of an expert and not necessarily specialized? So there's a lot there I just threw out. I can repeat what I just said, but he needed a drink to process it.
I'm going to take one too.
And again, no particular order. How does that all kind of play in? Because, people think you do OCSs or residencies and fellowships to specialize, but then you realize, you're able to take that step back and see how it applies to different realms. So I'll get to that in a little bit. I'll shut up and let you talk.
Okay. So I'm probably going to miss some of the questions, but
All
the first one I'm going to start off with is the joint or region specific specialization. I was not there at that one, but
I apologize.
Actually, weirdly enough, we had actually that same conversation next year without you.
Okay.
Because I remember talking to Pam in our fellowship class about that. And I kind of made my thoughts known on that. And she actually said, because she works at Intermountain Health, where they have tons and tons of data on outcomes. Yeah. And she said she pretty convincingly saw that those who specialized tend to have worse outcomes. And one of the follow-up questions was like, well, is it because they're seeing the hardest patients? And she's like, well, there's different ways we controlled for that. And she's like, the specialist still did worse. So I think that if you look at a person at one joint or one part of the body, you're missing other stuff. And I think we need to just generally, there's so much good information out there. If your information is only limited to one joint, that's great, but you're going to need to know something else about that body at some point in time. And that includes knowing other joints. It's going to know different types of, maybe you're going to have to know more about if you treat the back, you have to know about the cardiovascular system. What if someone has a AAA or something like that? If you're dealing with headaches or the neck, you have to have a really strong neuro game. You have to be able to do cranial nerve exam. You have to be able to differentiate between sometimes other severe neurological processes that could be going on. So I think we have to meld a lot of those skills. And obviously, I think the data that she kind of told me is unpublished, which always kind of stinks for listeners too. But anecdotally, that's what I've seen. And I've seen the people who do specialize, like people who specialize in the back. I think it would benefit or behoove them to be able to see other different areas too, as well.
Yeah, and
from what I've seen personally when I follow people.
Yeah, I think that brings into, just one topic we've talked about a lot is regional interdependence. How does, one or two joints affect something above or below? So, just from looking at, I think that's a simple example, let alone some of the more complex things that you said, which I don't think are that complex. If you're aware of it and begin to hone it and practice it, they should be more routine than not.
Mm-hmm.
Yeah. I work with a lot of occupational therapists, and at some of our facilities, they tend to get a lot of like the shoulders, elbows, hands, which is a little bit bums me out a little bit because I like to see them a little bit more, just, because I like that variety in case you guys haven't figured that out.
Mm-hmm.
But I tell them I've talked with a couple OTs about it. I'm like, I don't understand how some OTs won't treat the neck or the thoracic spine at all. And I'm like, I don't understand how you would be able to treat a region like the shoulder if you can't treat those areas.
Yeah.
Because I don't understand it. And it might be my practice patterns, but you need to have options when treating patients. And if you only have a limited number of options, there's just less good that you could do, period, for them. You need to be able to branch out and do other things, I would think.
Yeah, agreed. Well said.
Then from just another kind of side point is, especially those who specialize, you're going to get eventually to this point of like where I've seen it all sort of thing, and probably start repeating same treatments. I'm the expert, I'm the specialist in the area, and you miss out on that creativity side of like, sometimes, a lot of times I'm working with someone, I'm like, all right, I'm treating their primary issue, they've had a chronic issue elsewhere. I'm like, all right, let's focus on your first thing. And then as we're working with things, they'll start to report, hey, you know what? Since we've been working on my shoulder or my neck, my elbow no longer hurts, or those sort of things. So you're missing out on those components if you're kind of keeping yourself into like one special region or something of that nature. So I feel like you're missing a lot of the experimentation side of things, and, can definitely holding yourself back.
Yeah, experimentation side and really type 2 reasoning, that, clinically reasoning through things instead of always defaulting to that type 1 reasoning, which is your pattern recognition, which is something, we've just talked about today with your mentoring, mentoring with you today. And, obviously you need type 1 reasoning, you need that pattern recognition. It needs to be a part of your thought process and your clinical decision-making, but that can't be the only thing that you reach back into, and your bag of tricks is just that, because you're going to miss something, you're going to get fooled, you're going to overlook something just by always trying to pattern recognize.
Agreed. You need to, I think, pulling all that variety definitely is vital for people. I think like a good example of that might be like, you take something like a total knee replacement. We'll say a lot of people have seen a total knee replacement, and there's a lot of people who are like, oh man, total knee replacements are boring, you can't do this or that. For something as what appears as mundane as that, there's a lot of degrees of individualization that you can do. Yes, you have to get the range of motion. Yes, you have to get the kind of functional mobility training, but there's little tweaks and variety that you can do to get people better. And I kind of think about it like cooking. And sometimes you're still making lasagna, but maybe you're throwing like a little bit of different type, like you use a different type of tomato, or you like use a little bit of pinch of this or a pinch of that. And those pinches can make a very big difference on kind of that end result, or that recipe that you have at the end. If you don't have enough salt on stuff, it might not taste as good. It's the difference between like a good dish and a great dish.
Yeah. Well said. That I think that ingredient analogy is always a great one when it comes to treating and honing into clinical decision making, and not making things, no pun intended here, like cookie cutter. Speaking of recipes and stuff, you want to be able to add some variety. But Steve, with that, just to circle back, you did your OCS, you have this unique arc here that I don't think a lot of therapists really get to. What made you go into the fellowship program? And then how have you been able to, over the past, 2 years or so, take what you've learned, probably take a step back and see how it fits into maybe a bigger picture and across different realms? And we'll dive more into that later, because I know we've had some conversations about that as well.
So I think one of the big things is I think the feedback, the clinical growth that you get with like kind of like a targeted residency or fellowship program, that's going to kind of put your feet to the fire a little bit more than kind of just doing stuff in clinic and be like, I think I did a good job. And I like to think that I'm pretty critical of myself, and I tend to try and unbiased evaluate myself, but I'm evaluating myself. There's going to be a level of bias. So I think the fellowship process has been helpful in that capacity for me. I think that's part of what drew me into it. I think particularly drew me in the Regis too. It wasn't saying we're going to have you follow this book and pamphlet of what you need to do with all of your patients. Because if that's what was going to happen, I feel like I would have lost a lot of the things that make me an effective therapist. And I think the Regis program kind of is a self-reflective program. It doesn't make you treat a certain way. And I think that was really what appealed to me in that, because I don't think I would have gone into it otherwise. And Joe Byland, who was one of my mentors at Mount Sinai Hospital, now whatever 15-letter name that hospital is. Yeah.
Is my mentor as well. So we share a mutual one.
I think it's like Hackensack Meridian Health, something, Mountainside campus or something.
Yeah.
But it is, I think that's kind of what drove me in there. And I knew that I have a skill set, and to be honest, I wanted there to be kind of a structured way for me to show my level of expertise. And I think that's a problem that we have in our profession is there's some ways to show expertise, and traditionally the way to do that is either residency or fellowship, becoming board certified or getting that fellowship. But there's a struggle in our profession for some to show expertise, because let's say you go into cardiopulm. There's not a lot of cardiopulm residency programs. There's no fellowship programs that exist for you. And while I understand the push to require residency after DPT school, I don't think right now it's not a viable option due to the lack of availability, the finances in it. And that's one of the things that we need to find ways to be able to find people who are skilled and expertise. And right now it's challenging because it's a hard thing to do.
Yeah, it definitely is. How have you been able to use manual therapy in your other settings? We've talked about, and that was a point for at least that came up on my side of things in the AMP conference. We keep doing these manual therapy things, Manips, whatever, pain science, name down a list. But then it's like take a step back and you alluded to it earlier. What about that cardiopulmonary patient who had open heart surgery and is stuck, in kind of that kyphotic flex position? They need to be able to open up. They can benefit from manual therapy. Mm-hmm. What about that spinal cord injury who needs neurodynamic or even, spinal mobilizations to kind of open things up and help facilitate healing? That if you're in those settings, you have that tunnel vision of, why would I do manual therapy on this patient? Mm-hmm. How have you been able to bring that together? Or when was that aha moment of, I guess during fellowship, maybe it was before fellowship, I can use manual therapy for these unique populations that you see?
I would say it started even before PT school, actually, and to a degree. I was fortunate with my, the treatment by some of the physical therapists that I had. And also I had an excellent kind of populations health class when I was in exercise. When I was a health and exercise science major at the College of New Jersey. And those things kind of made me start thinking, there's some great things that we can do. So we're going through stuff kind of traditionally speaking. And I'm like, okay, we're seeing patients in the hospital. And I started off as a physical therapy aide working in outpatient and also the inpatient setting. I was like, why are we using any of this population health stuff for the people who are inpatients? Mm-hmm. I know I was able to get a rapid improvement with some of the different techniques that I saw in an outpatient setting. Why aren't we doing these things? So I kind of knew that it was possible. And then as I kind of have been going through over the years, you try stuff out and stuff doesn't work and stuff does. And it's taken me a while with some things more than others to figure out how it meshes together. I think in terms of applying some of the population health stuff, I've gotten a lot better in that in the last couple of years. The manual therapy, I had pretty strong, I had a lot of continuing ed in manual therapy early on in my career. So then it was easier for me to start using some of the manual therapy for like my patients with traumatic brain injury. I started working when I was working in the acute care setting where you have people who are post-cabbage, and I'm not saying you have to do manual therapy with everyone post-cabbage, but for people who are severely limited by pain, dyspnea, those types of things, a well-timed or well-placed manual therapy technique isn't going to really take too much of your time up, and it can also yield much better outcomes for the patient. And that's what we should be focused on in that setting, not necessarily just seeing as many patients as humanly possible. We should be focused on adding value to their care in that setting. So, I mean, other areas that you could include that manual therapy in, talk about like we talked about the neurological setting with our geriatric patients using well-placed manual therapy to help out even something like balance. If you don't have mobility in different areas, then you're not going to be able to, you might have to make up for that with stability somewhere else, and that can impair your balance.
Yeah.
So there's a lot of different ways you can kind of use it.
Yeah. To kind of go off that, I had two unique experiences. I guess really two individuals I was lucky to have in my path. One was Craig Fox, who you know, and he's what's the company he's with now? Neuro Rehab Institute, or I forget the name of the actual.
Are they all? I thought they were all consolidated under EIM now.
Oh, is it now that? I thought they still had their little sub umbrella underneath EIM, but
I know Kineticore and like ISPI consolidated under them, so I figured they did, but I don't know for sure.
Anyway, he's the lead there. But when I met him, he was at University of Florida, and I had a 12-week rotation of Neuro PT, which I wanted to do orthopedics and sports and stuff like that. But I had a great experience with him, and he was like, just because they're neuro doesn't mean they don't have orthopedic issues. Doesn't mean you can't do exercises with them. That was the first time I really kind of heard that and was just like, wow, you're right. And he made it much more enjoyable for me because now I was able to apply some ortho in there and kind of get my little fix there, but also understand the neuro side of things. I remember doing some manual therapy on patients with Parkinson's, rigid T-spines, they're progressed far enough where they're lacking a lot of motion. Hey, do some manual therapy now. Let's do some motor control stuff and a lot of repetitions. At that time, I was very, very, very big into like exercises. So, we had some spinal cord injuries and some post-stroke patients. He's like, you can do anything you want with them. They need more reps than the average person. So just kind of hearing that was just like, kind of shed things in a different light where you can, just because it's called Neuro PT or cardiopulmonary PT or whatever, doesn't mean it just has to focus on those systems. And then the other one was during my residency with Bill Egan, and we were talking about we were going over the neck, and we went over vestibular, and he had mentioned he wanted to get better at vestibular, so he took a vestibular course, and he's like, yeah, a lot of it was aside from like some of the BPPV stuff and things like that and habituation, it was a neck screening. And I've realized treating now, years later and reflecting in the growth, like a lot of the vestibular patients I've come across have benefited so much from mobilizations or manipulations to that upper C-spine or C-spine in general, and then combine them with, some other things as well. But a lot of them tend to come chronically, they've been elsewhere, and that seemed to be the missing piece. They've been dealing with X, Y, and Z for 6 months, a year, 5 years, and then you do some manual therapy, and it's like, wow, things really open up. So just really having that clinical decision-making to try new things. And as you've been doing really since undergrad, pushing that envelope, challenging the system, we need more PTs like that.
Well, and actually one of the questions I have for you guys too is when you're talking about this and like the mentors that you've had over the years, they challenge you to use an orthopedic manual therapy approach, and that's what I know we talk about in the Regis program. And really, how much of that is just that patient response model, or that test retest model, is a clinical decision making approach that is used a lot more in orthopedics. Sadly, not as much as it should be, I think. But why aren't we using that in other settings with different patient populations? And you just kind of talked about how that approach and how kind of on a larger clinical decision-making scale, how that can affect the patients that we see and how we can maximize our outcomes by communicating across these silos, basically across our field, I think.
Yeah. I mean, going back to one of our previous episodes where Brandon was making the argument of like manual therapy it's always labeled non-specific effects. Brandon wanted multi.
Yeah, well, it was a podcast or the course we had. Anyway, regardless,
it's both.
Podcast,
maybe both.
Multi-specific effects.
So to multiple regions, to multiple systems. Like let's say manual therapy. All right, there is a calming effect to it. So can that alter people's BP or heart rate, or can we
anxiety?
Can it alter things in the nervous system as well? We've seen it. I talked to Brandon about this. He brought this to light for me at one point of, I've had manual therapy and he's had manual therapy alter reflexes. So that's a neurological response. It doesn't have to purely be manual therapy. I'm just using these examples, but looking at it from, it can affect multiple systems and we should be using it in multiple settings. And I think like students, I know in my experience that you guys had similar experiences. I had my outpatient orthopedic experience under a COMT, certified orthopedic manual therapist. He was OCS, a little more older school, super smart guy, Terry Andrews. And I learned a ton from him. And then I went to inpatient. And I could have just kept quiet, just treated, the strokes, the cabbages and all that. But there was a time and a place, patient couldn't get his hip up for like stairs or something. I was just like, well, if we just did some hip mobilizations. And I had good enough CI, Wendy Jensen, was just like, why don't you try it? So don't be discouraged even at the student level or anything like that. Just be like, hey, why don't we try something outside the box? Because even as your CIs, you get tunnel vision. You've been doing this for years, suggest some of these other system approaches, and you can definitely help some of these people out. But sorry, I went on a tangent there.
No,
it's time to drink.
I think Steve, you brought up a good point, and audience, replay this, because that utilizing test retest, which really comes from Maitland, right? When we break it down. And it should be used in orthopedics, and it's probably not used in musculoskeletal orthopedic settings enough. So we know it's probably not being used in other settings, and it really should. And that needs to be taught, I don't know, whatever level, continuing education courses, residency levels, entry-level PT, between courses, like that needs to find its way to trickle down. And hopefully this podcast can, reach a few hundred people, and hopefully will resonate with some people, and they'll start trying to bring that concept over into whatever setting that they're in.
Yeah. And I mean, sometimes it's harder to get people, like when have someone with a lot of severe neuro deficits, you might not be able to do a manual therapy technique or really any type of intervention and be like, oh, you went from a max assist transfer to walking independently.
Yeah, it's not going to happen as quick.
Yeah, of course.
But what you do is, as you also get more skilled with it, you get appropriate tests that you assess on people. And there are some times where the patient response model, like getting results on that, is not a huge deal. If someone's like max assist and we do 100 transfers to that person and they don't change at all, but next day they're doing a little bit better, maybe that retest didn't do anything from that session, but they just needed repeats. They needed repetitions. Mm-hmm. And I think that's also something I've kind of learned over my career too. I like that model. There's limitations. We know those limitations, but on the whole, that model can really help our patients out.
Yeah.
And I want to actually say something to you, Jeremy, because you mentioned about like manual therapy with like blood pressure and vitals, anxiety, all those different types of things. There's good research for all that stuff. And I've definitely, like with someone who's high blood pressure, who had high blood pressure, and I was like, they're kind of on the borderline. I probably shouldn't see them. I do some manual therapy, get their blood pressure down. I'm like, okay, now I can start mobilizing this patient cautiously, monitor their vitals, kind of see how they're doing. And in the hospital, mobilizing someone versus not mobilizing someone, like that, you can avoid a serious medical complication like PEs, pneumonia, that kind of stuff by mobilizing people. So that's not an insignificant effect.
Yeah,
absolutely.
And probably something that's not going to show up in the research too often.
No.
You know, a lot of research is confined of, you know, excluding people with a lot of these comorbidities or age restrictions. And even in school, we learn manual therapy is contraindicated for probably half the stuff that we utilize it for, or it should be utilized for. So it really comes down to, as you said before, that clinical decision making, that thought process of being able to reason through something.
Can I ask you guys a question too? Because this is something I've been kind of playing with in my brain, is like in the acute care setting, I think there is value we can demonstrate for patients, basically, if you just refer to this whole entire conversation that we had. But one of the challenges you run into is that patient you might see for a one-off visit, and it's hard trying to demonstrate value in that one-off visit. And yeah, maybe you could do like a Berg scale in the beginning and a Berg scale at the end, but let's be honest, from a time perspective, you're not going to have that option. And I was kind of wanted to pick your brains on things or outcomes or ways we could capture that from an orthopedist, from orthopedic physical therapist viewpoint. I'm like, can we use something like the GROC, even though I know that assessment really doesn't have like the best validity in the world? It's like, how would you guys try and capture the value of like a manual approach, or really any type of clinical decision-making approach with a patient like that in acute care where you might only see them for one visit?
Yeah, I think I'm going to ask a follow-up question. Is what type of acute care are we talking? Is it post-op acute care? Like, I think it definitely values or varies depending on the complexity of that patient and what they're in for.
Mm-hmm.
Yeah, I think really.
And in acute care, I feel like you're getting such a huge spectrum of that.
You can go off a lot of things. I mean, I think whether it's a post-op, which would be more, or, you know, post-op, you know, musculoskeletal is obviously more our realm, but I mean, yeah, it would be tough to quantify those things, but yeah, using like a G-Rock, or maybe it's distance walks, or maybe it's something as simple as compliance. Most of our, let's face our acute care, or for all acute care therapists, go out there and how many times they get rejected going from one room to the other. And maybe as a buy-in, and maybe that gets enough for the patient to be like, you know, these people are out here to help me, and maybe I won't be, you know, saying no to the next PT who comes in, and those sort of things. So something you can't really quantify, but I think especially with that manual therapy approach, which has probably a better buy-in or a bit better patient rapport than just, hey, go sit the stand for the next 5 minutes. Maybe that's something that we can quantify, or, you know, maybe we can do a post-discharge research on, you know, individuals who got a manual therapy approach versus didn't. I'm sure functionally they may have, you know, 6 months down the road look the same, but how quickly did they get to that point, or how satisfied were they at, you know, 1 month, 3 months, and those sort of things. But go back into Brandon's follow-up there.
How I would look at it, or again, it's a small niche. People with bed sores or tunneling and things like that from lack of movement, and maybe we're going into more subacute cares as well. You know, I think we should be mobilizing these, or passive range of motion even, which clearly doesn't get done. Can we start there? Are we getting
contractures too?
Contractures is another great one. And again, maybe they're not that, like Jeremy said, that short time, but you know, if you're seeing it and then, you know, the guy behind you in the next shift is doing it, does that shorten length of stays? Are there less adverse effects? Are there less contractures? Are there less, I'm totally blanking
cost.
on reduce cost. Yeah. What's the word I want? Tunneling when bed sores and stuff. Yeah. What's the term for that called?
No.
You're talking about like the depth of the wound?
Yeah.
Yeah, but what's the wound itself called? Is it?
You're talking about decubitus ulcer?
Yeah, ulcers. That's what I was talking about. Okay. Just ulcers in general. Yeah. It was escaping me, but I know I was naming the grades. I was going way higher than what I needed to go. Typical me there. But yeah, are we getting people with less of that stuff from, you know, either some type of passive range of motion or joint mobilization, like he said, PEs, less clots and stuff like that, from mobilizing, from early PT recipient, you know, care wise. So, but I think that's very hard to really try and get into research and then show actual change. I don't know. I'm not the research guy to talk to you about how that would go
I think
about.
it would
but
be
yeah.
like a cost-effective study. Like I remember we looked at a comparison. My research in PT school is a comparison between SNFs and a day rehab. So nothing changed besides a patient instead of sleeping over or was driven in. That was pretty much rehab didn't change, but the overall cost of everything was significantly less than day rehab, and the outcomes were exactly the same. So it's like, all right, this is for total knee replacements and maybe total hips as well. But if we're avoiding all these sort of things that, whether it's tunneling or ulcers or, P's and those sort of things, decreasing the cost of or readmissions and those sort of things, looking at that, can we do a cost study as well? Maybe versus purely, their outcomes are better, their wounds healed quicker, those sort of things. So those would be tough to quantify, but maybe overall cost of a patient or length of stay and that sort of stuff.
It's tough because even like if you look at stuff like early mobilization, sometimes they don't show differences in some of those outcomes, even though like early mobilization is such a valuable thing. And then like you talk about like there's some patients like I might go a whole day in acute care and never use manual therapy, and that's fine. But then there's some days I'll use it like 4 or 5 times. And speaking to like getting people to engage in therapy a little bit more, like there was a guy who I wanted like, oh man, I want to write a case report on you so bad. It was a guy who had basically metastatic cancer. He was going on hospice, and those are typically people in the acute physical therapy care setting where they're like, okay, well, do we need to see this person? Are they appropriate? And it's like they don't see a value that we can provide for that patient. And so I went into that room and I was like, oh, how are you doing? What's bothering you? How can I help you out? He's like, I don't know if you'd help me out with this, but he's like, I'm really constipated. It's like this. The drugs have really backed me up. And I know my little bit about trying to help people go to the bathroom a little bit more, talking about positioning with that, mobilizing, moving around, giving them different ways or different techniques to be able to do that. And am I the most knowledgeable in there? But no, but I have conservative interventions that someone can do that is dying that are important to him. And it's just hard to quantify something like that, even though I know I had an impact on him. It's just frustrating that I can't demonstrate that value.
Yeah. And I think that'd be a great case report, because the deeper I've gone in the research and clinical expertise, right, with residencies and fellowships and not presenting and stuff like that, I find more value probably nowadays in those case studies or case series than those randomized control trials. I think, obviously we're taught that, and this seems to be a recurring theme on the show, and it's not that we're poo-pooing the grade 1 and 2s of evidence, but those have a limitation on it. And what if you have that patient who has metastatic cancer, who can't go to the bathroom, who responded to some type of mobilization or self-positioning? That's not going to be, you're not going to find 150 patients like that you can study and try and make it generalizable. No, that's a one-off patient that, there may be 5 of those, I'm just throwing out arbitrary numbers, but that, somebody who reads it and they run into something similar, whether it's a cancer patient or not, but something of the like, and they're able to now help this patient off of a case report that was written up. So I find more values in that, because you gain insight to that reasoning of the therapist, what they tried, what they didn't try, and things like that. So, it might be beneficial. I know you're very busy as it is, but that might be a unique presentation, or maybe it's not a write-up. Maybe just do another poster next year for Aon Thursday.
There you
go. Maybe.
Hopefully it gets out a little bit with the podcast.
Yeah.
But
we'll promote it here.
Yeah, and another way, I guess not really quantify this or something, but I used to do inpatient rehab, or I guess it was a sniff, when I worked. I was going through my orthopedic residency. It was a way to pick up side money. was never, I always kind of thought I sucked at it because, you know, it just wasn't, you know, most of the time I was reading orthopedics articles and stuff like that. But I would go in, I had the same approach I've always had, like whatever the patient needs right now, I'm gonna help them out with. I was not a productivity friendly therapist at times, but whatever. And something that always happened, I was like, these guys must think I suck. I don't even know what to do with half these damn lines half the time, but I like cared. I would, you know, give them exercises to kind of help them. I ask the same question, what can I help you out with today? Sometimes I integrate manual therapy, and almost every single time at the end of it, they're like, when are you coming back? I was just like, oh, no, you're probably not going to see me ever again. Maybe once a month, they'd be like, oh, Jeremy, you want to work? I was like, maybe, yeah, why not? But it was always like, this is the best session. Not always, but a lot of times, like, this is the best session I've ever had here. And like, you know, they come in, like, they're miserable about those sort of things. So that's something like, hey, you know, you're doing the right job. Again, it didn't have to be manual therapy. It could just be like, all right, listening to the patient and doing something right there and then. But that is maybe not a research way to quantify things.
And then you guys both said it comes down to caring, comes down to going the extra mile, having passion for what you do, your job. It's not always easy. Like there are some days where it's like, I'm going to mail this one in. But what if that guy needs you that day and you're just being lazy? You know, if you just take that extra 30 seconds to ask that patient, you know, that reward you get is going to just kind of make you want to do more in the future, and then avoid burnout and avoid, you know, the monotony of it, because you're actually going an extra mile and you're making a difference. And that's what keeps you going and avoids that burnout in our profession. So
on that day that I saw that hospice patient, it was a rough day before that. And I saw him and I was just like, I don't care about what else happened this day. I feel good about this. This was a good day, and I'm glad that I approached it the way I did and that kind of stuff. Because you're right, that's what gets us through.
Yeah, because you know, it probably would have been easy for you to be like, I'm just gonna mail this one in. I know that's not your personality, Steve, but little story about Steve. When this had to be like is this the first weekend we had together? I don't know, maybe first or second, maybe a second, and he's like, yeah, I read the Guayet, or I don't even know if I'm pronouncing that dude's name right, research book every night before bed. I'm like, what the fuck? This dude's serious shit. Like, I'm like, I can't even read like past a page and I fall asleep with that. And this guy's reading it like 10 pages a night before bed. I was like, this dude's legit. He's definitely taking this to the next notch. And I was like, I kind of took it as a challenge for me in a good way, Steve, where I was like, I need to step my game up. Like, this is what it's about. You know, you got people here, you know, and he'd stay up till like 2 or 3 in the morning. And I was like, at like 1 o'clock, 12 o'clock, I'm going to bed. And that was like a wake up call to me. I was like, I need to step up my game and really, you know, not try and coast through this, but really pull out as much as I can. And will you know, Steve definitely is part of that. I will never forget that when I heard you that awful book, man. So
I remember your response. You're like, whoa, you're just not reading the articles online? I was like, no, I'm reading the whole book. Like, I figured Josh Cleveland told me it was a good idea to like know the book front to cover. So I was like, I just read it front to cover.
Yeah. I thought I was doing good with just the articles, but he took it the step above. So
I feel like I still could get better at it. So I'm still a work in progress too, because I feel like you had a much better foundation than me coming in through your residency with the research. So I feel like I had like catching up to do. I was like, okay, I gotta get my game up, match you.
I think you caught up. Did you ever finish the book?
I did, yes.
How long did it take? I need to know, because I didn't get to
it. Did you read it?
I still haven't gotten to that point.
I would say it's like a year. It's great. I save it for times I know I want to fall asleep. Yeah. So like I'll read a few, like I read it for like 10 pages at a time. Like airplanes, it was perfect because I'd like read it, I'd fall asleep. I get uncomfortable. I'm like, oh, I need to fall asleep again. And I read like another like 10 or 20 pages. Or sometimes I would just stay up and I'd be like, I would knock out like 40 or 50.
Yeah, I went back to, I'm just going to read these Note Boom articles by Note Boom in Cleveland. They seem to cover everything in that book that I need to know. Another thing that you, funny story, that you love and I hate is that Painful Yarns book.
Oh,
Remember that was brought up in class. We were talking about analogies. I brought it up. I was like, I couldn't stand it, but that's like a good example. And you're like, I love that book. How can you not like it? I was like, dude, I fell asleep every time I read it.
The Hammerhead Shark didn't make you like roll over laughing.
Honestly, I don't even know if I got to Hammerhead Shark. I remember this was in residency. I had my Heidi Oja she was my like personal like advisor, I guess.
Yeah.
And she was brutal on me, probably because I didn't read the book. But every time we'd meet, I was like, yeah, I'm still working on it. I can't get through it. Like I was genuinely trying. I'd read like a page and fall asleep. Or I'd reread the same page like 10 times. And I remember like they had an analogy. I should go back and read it now 7 years later and see if I can just understand things better. They had an analogy about a car. And I don't know, like I gave up at that point. I was like, what the fuck are they talking about? I had no idea. So I probably didn't even get to the Hammerhead Shark. Maybe I'll start skipping through and see how I start with that. Do you remember
that's one of the few times in life where I've read something and I was uncontrollably laughing so hard. Like I couldn't breathe. Jeremy, have you read it?
No, I have not read it. I think based off of his advice,
I turned him off to it.
I went deep down the pain science route and everything like that. And I remember him mentioning how awful it was. So I was just like, oh, I'll just read like the Adrian Low pain books and stuff like that. And
much friendlier. They have pictures, they pop up pictures, much more.
I'm gonna have to get it now just to either get a good laugh or
it's a little useful clinically, but it's not super useful. It's like good for just more story ideas. But I thought that was the funniest of the bunch. Like I have like the Explain Pain books and all those other things. But I thought, I don't know, that was funnier. But
it's written they're from Australia, right? The guys who wrote it?
Yeah.
So I think a lot of the analogies were like Australian specific and at, I don't know, what was that, 27, 26 or whatever? I don't know. Just like went over my head. I guess maybe I just wasn't cultivated or cultured enough. And I was like, what does this have to do with my guy having pain? I just missed the boat completely. But anyway, I'll have to go back and read it.
Fair enough.
All right. I guess enough of that. I think anything else, you guys? Steve, anything else you want to share before we do our wrap-ups?
No, I think we covered a lot if So I think, I'm personally happy with it.
Awesome. Great.
Yeah, great episode. And thanks for listening in. And if anybody had any questions or anything like that, comments or concerns or wants a mentorship or anything like that, feel free to reach out to us at Nips and Sips on all your major social media. I'm at The Decent Doctor and at Trifecta Therapeutics. Brandon's at Think Like a Fellow and at Pursue PT Now. What about you, Steve? You got anything?
Right now, no. I am social media. Well, actually, you can follow me on social media, I guess, if you want. I am active on Twitter-ish. So at Steven_Kinney PT.
There we go.
Nice. All right, we'll find it. We'll start following you.
Awesome.
I guess just last closing up, we have just a little shameless plugs here. We have our manual therapy video series, over 120 manual therapy videos, step-by-step instruction, including spine from OA and AA all the way down to L5 S1 region. I guess peripheral extremity mobilization and manipulations, and we've just recently added neurodynamics. Also pop in some stuff from live shooting from our live courses that we have. So if you guys want a little bit more instruction with your manual therapy and things like that, check out that. We're having a Black Friday special, I forget, like 35% off, I think. And then what's really starting to take off now is our mentorship program, where you get to pick myself, Jeremy, and Dr. Kyle Feldman's brains basically on a daily basis with our discussion thread and discussion board we have. We also have bi-monthly calls, over 600 fellowship level articles that have kind of been vetted and read by us here at the higher level. A ton of other resources there. So any questions on that or interest, please reach out to Jeremy or I. We'd be happy to help answer any questions and get you rolling on the mentorship side, guys. So other than that, that's it. All right, guys.
Cheers.
Yep. Thank you for having me.
Yeah, thanks for coming on the show, Steve. And we're definitely going to have you on probably 2 more times, at least, if not more. And I have a feeling we're going to start working together a lot more in the education realm, Steve. So looking forward to it, man.
I look forward to it too. Yes, thank you. I like all the offerings that you guys do, and you're taking over the education world as you should.
Trying.
There we go. All right. Thanks, Steve. Cheers,
right.
Everyone. Cheers.
Thank you.